And to continue, first, I have to disagree with you, John. After knowing her a bit yesterday evening, I guess the meeting is not balanced, and we should have more male speakers on the podium to balance her and Eva. So let me introduce Dr. Beatrice Lejeune from Belgium, working and living in France. She's not a dentist, but as all other scientists that enter this community, they immediately fall in love with all of us, and we'll sure have them back for, to learn what's more, because for her 1 hour is not enough as well. So please come up to the podium.
Okay, so that was indeed a very, very nice introduction, and is it working? Yeah. It's really tough for me to come right after Dr. Lechner, because I had the privilege to cross his pathway in a congress, because he worked with our medicine. But he used a medicine for multiple sclerosis just because it had Rantis in it. So I told him, why do you scare patients prescribing multiple sclerosis medicine to someone that does not need multiple sclerosis medicine? And he told me, okay, what do you suggest? So we pretty much made Rantis for him. So what we did was, okay, you have Rantis to treat your patient, but are we sure it's working? So this is the results of the follow-up he did using our medicine after he treats the patient, as you've seen right before. So the first thing is, well, I apologize. I'm the only one who's not a dentist here. So first of all my apologies for not being one of you guys. But the rest is, okay, I have a conflict of interest because I'm from a pharmaceutical company. So I have to let you know about it before talking about this. The first thing is, as I said, okay, I'm an industrial pharmacist. I'm Belgian, so as you can see, I speak French. And after that, after I got my industrial PharmD in there, I moved because of my husband to the University of Florida. And I became research associate there, and I had the chance to work in the College of Pharmacy in Gainesville, and that was the basics of pharmacogenomics. So I was one of the first ones to work in that field. Then we had to choose between, who's going to go into research, husband or wife? I got offered the position, he got the position back in Belgium. Guess who won? My husband. We went back to Belgium. So I got into Labolife after that. And this is my current position. I pretty much had all the possible jobs in that company. Was QA, QP, whatever Q you can find, I got that. And at the end, when again, I moved to France because of my husband, who got a position there. They switched my job, and I ended up being head of regulatory and clinical affairs for the group, meaning that I have the chance to have 40 nice person working for me. So I really am privileged to have all of those people working for me. I'm also responsible of medical scientific information for LaboLife Belgium. And that's just for you. I don't know where you are. That's a gift for you. This is real Belgian waffles, okay? Because also, since I had a big mouth, I said, no. From a pharmaceutical point of view, you don't know how you should sell medicines to pharmacists. And so they said, okay, you have a big mouth, you handle it. So I ended up being sales manager for Belgium also. So now I live in Nantes, which is probably one of the nicest cities in France, because you have good wines, good food, nice people, and you have the only not living and moving elephant on earth. You should go and see it. It's really great. So this is about my conflict of interest. You've seen the name of my company. You've seen it once. You will not see it anymore. So that was for the first explanation about myself. So I think that before going on a little bit further on, I need to explain to you what microimmunotherapy is. I know some of you know Guna, but which is a company that manufactures microimmunotherapy medicine in Italy, which I work a lot with because they distribute our medicine there, so I know them pretty well. But for those of you who do not know what microimmunotherapy is, I thought it was interesting to explain to you the basics of what they were. So what we use as active substances, it's only immune system mediators, meaning that we use cytokines, chemokines, growth factors, also DNA, RNA, and specific nucleic acids that we target for specific viruses, for instance. So mostly what we want to do is to use the message used by the immune system to rebalance it when it goes completely crazy. Going crazy may be working too much or not working enough. So we use those proteins at different levels of dilution to rebalance the immune system. That's also what I said. Those are specific nucleic acids which are patented. And our medicine are sequential. Because as you know, when you look at how the immune system works, just a regular inflammatory reaction, you start by having something wrong in your body. The macrophage that's around it just discovers it and says, oh my gosh, that should not be here. So he releases cytokines to tell the other macrophage, hey guy, need help. So they come to you. They help this one. So they release another one. So the antigen presenting cell can get that substance, present it, and so forth and so on. Which means that you do not have just one reaction. You have a cascade of different reactions going on. So that's why our medicine are sequentials, because we want to mimic exactly what's going on in the body. We manufacture those cytokines, most of them ourselves, using recombinant DNA technique. And that's really cool because that's also part of my team. So that's really neat. And the modulation of the dilutions we use is quite interesting because it doesn't have anything to do with homeopathy. Because what you work with is immunological molecules that you have in your body. So it's not the same as using something that is outside the body and that you will use and dynamize. So if we use low dilution, you will have a stimulatory effect. If you use high dilution, you will have a reduction of the effect, which is called a braking effect. And that's fairly easy to understand when you look at this, because this is an explanation for, I work a lot with classical physicians, which will tell you that homeopathy is bullshit. Oh, sorry, it's crap, sorry. Yeah, sorry. So when you have to have them understand it, you need to explain the thing using their terms, so they will get it. So when you go up to 5CH, you will still be within physiological action, because what you have is something that is still in the concentration of your physiological system. In between, you get to a gray zone. You know, it's a modulation. It goes on or it goes off. And above that, up to 30CH, we don't, well, it's quite seldom we go up to 30CH, but 27 is quite, it happens quite often. You get an inhibiting effect, because there you can pretty much share homeopathy with it, because you have a reverse effect, which means that you can use exactly the same cytokine, but do the opposite. You can use TNF-alpha. If your immune system is too low and you want to speed it up a little bit and speed up the acute phase, you can give TNF-alpha at 4CH. It's not a problem. But if you have an inflammatory reaction, or in cancer, whatever, you can give TNF-alpha at 27CH, and that will have the opposite effect. So that's pretty much how it works. Of course, now, what you want to avoid is using the term homeopathy. That's bad. You don't want to use that. And basically, we don't call it homeopathy. It's microimmunotherapy, but still, it's in the homeopathy zone. So now we come, like Guna, with low dose and ultra low dose dilutions. So this is a little bit to explain what I just said. This is a slide I use with physicians. If you want to stimulate, it's really easy. You know, Le Tour de France is going to start quite soon. So this is EPO, guys. Perfect. So those are the receptors, and what you want to do is to have your EPO going to the receptors to transfer the info. So when you think about the lab reference through ELISA techniques, you can measure EPO until between 26 to 143 picogram per ml. If you think that what we call mother tincture is 10 microgram per ml, a 3CH dilution is at 10 picogram per ml. So you are exactly in what can be measured by ELISA. So a 3CH dilution will have a stimulating effect because it's a physiological concentration. So thank you. So that's the easiest one, because everyone gets it. Easy enough. Now, that's the tricky one. How can you explain to someone that at 27CH, you still have an action? Because, of course, you don't have anything left. You know, nothing is there, in theory. But what we did is, you have several aspects of it. You know, you can talk about dynamics, you can talk about vibration, you can talk about whatever you want. But what we decided to do was, since those are not classical things, they're proteins, we wanted to see if we still had something with those proteins while you dynamize it. So here you just see dynamized ethanol. This is the measurement of the number of nanoparticles you have. It has been done, the machine is called the Q Nano, and that has been done in the University of Nantes. I have good connections there. So that has been measured at the University of Nantes. And we did it, for whatever reason, we decided to pick Rantis. So this is dynamized ethanol. So you see that, of course, you have nanoparticles in there because when you use ethanol, you will not use ethanol ultra purified. 96% ethanol is extremely expensive. Ultra pure 96% ethanol is totally unaffordable. So, well, you know, we're in the pharmaceutical business. We're trying to make the more out of the less. So this is dynamized ethanol, and this is what happens when you have a 4CH dilution of Rantis. You see that those nanoparticles, you still have some there, which are in the same range. And then you see that you have larger ones after that, which is, it's like the imprint of the molecule. So that is 4CH. Easy enough. It's there. Physiological. But then, this is the interesting thing. This is 27CH, meaning there should be nothing. And this is what you get. You have pretty much the same peak here. Here you have larger particles, and you have pretty much the same amount of them as with the 4CH. And when you show that to someone that is completely strict and say, no, there's nothing there, that's touchy. You touch something you should not have touched. So as you can see, Rantis 27CH is still there. I cannot tell you what is there, what type of nanoparticles you get. Either you can discuss it, it's silica, it's whatever, but you have stuff. So even though you shouldn't get nothing, you still have that Rantis there. So this is for the dentist part. I will go very fast through this. Microimmunotherapy medicine have to be administered by sublingual route, which means that it's really nice for the patient because you just have to put the globules underneath your tongue and let it melt. It's quite harmless, except if you have ulcers, but in theory you shouldn't have ulcers. And why do we do that? Because here you have all the salivary glands, and this neat little one here is the first part of the immune system. When you get on stress, first thing you will do is release EGF from there, epithelial growth factor. Why? Because it will protect your stomach and your heart. Put a mouse on stress, first thing he will release EGF from here. Then, of course, you know that underneath the tongue, you have lots of blood vessels. And just wait. It's empty here. It's coming. And then, of course, you have all the lymph nodes there. So we come to that. I stole this from a an article that was published in Nature on SLIT, sublingual immunotherapy that they use for allergies, because it fits perfectly. So here you have the epithelium, and you put the globules on the epithelium. The globules are sugar-made. You add saliva to it, it melts, so it becomes liquid. Then what happens? It will cross the epithelium and then go in contact with the dendritic cells, and then within the epithelium go to the oral lymphoid foci. Then after that will move to the lamina propria, to the lymph node, and then be transferred to the blood. So it goes from the saliva up to there. That's the point of the microimmunotherapy medicine, is just to be crossing there and go into the blood. Does that answer the question? Which one?
On the top left hand.
Here.
Yeah, you say the first thing it does is release a hormone, is it, or?
No, it's epithelial growth factor.
Yeah, and is that released into saliva or is it released into the blood system?
Into the saliva.
Into the saliva.
Yeah.
Right. Yeah, that
Oh,
was
okay.
the question.
I thought it was
answered.
this. Okay,
no,
sorry.
No, but you answered the question.
Okay, thank you.
Cool.
So now, how could this neat little protein here, at such a high level of dilution, be beneficial for your patient? And that's where it comes with Dr. Lechner's presentation before that. I will present you the summary of the follow-up that he did, and we published in the Journal of Biological Regulators and Homeostatic, not pathic, agent. If you want a copy of this, I brought about 10 of them, so you can take it. So the goal of this was see if, after doing the surgery that you've seen, the situation could be improved by modulating that inflammatory pathway through the addition of 27-CH renties post-surgery. And if it would indeed help reducing the renties plasma level. We decided to do it on the plasma level because it was a lot easier, because once you have taken the lump out, it's kind of difficult to get it back. The plasma is there. So you can take the first sample before and you can take the same sample a month after that or even after. It's not possible in the jawbone. So the treatment was do the surgery and then add that renties 27-CH 1 caps per day during 1 month. This is, okay, back to commercial here. This is registered to the federal agency in Belgium under that number. The population that was treated was 41 person, 16 male, 25 female, and 5 untreated controls. And the analysis was done measuring renties serum level at V0, meaning prior to surgery, and then at V1, in theory, after 1 month of treatment. But that's not always possible, especially when you're that famous and you have patients coming from all around the world. It's kind of tough to tell them, excuse me, could you take this and come back in a month because I need to have my blood taken. So the patient sometime went from 20 days to 526 days after taking the treatment. But that's not a problem, you'll see. So what about the results? Well, they were quite different than what we expected. Not that it did not work. It was really surprising. So this is the blood treatment measurement procedures. So the blood was collected, and then the measurement was done in serum using this type of chemokine panel. I'm just saying this because quantification of cytokines really depend on the type of technique you use. And if you start working with one lab, please keep on working with the same lab. Because if you change, sometimes they do not use the same kit, they do not use the same technique, which means that sometimes you can get different results, even though they are really reliable, but you can get 10 micrograms in one lab and 40 in another one. So please stay at the same lab. So first question, which is probably the most interesting one, is giving Rantis 27-CH useful or not? Here you have the patient that have not been treated, 5 patients. Here you have the average of the patients that have been treated. What do we see? It goes up, it goes down. So that's pretty much what we expected. So the answer to the question is yes, but damn, it's not significant. For a scientist, when you do not have P equal 0.001, it's just junk. You just throw your data away. So, of course, here the untreated population was really small, but you can see that there is a trend. So we did not get discouraged. We kept on. And when we analyzed the data, we saw something really weird. We had a very specific cutoff of 40 nanogram per ml at V0. So here you have the patient with less than 40 nanogram per ml of Rantis at V0, and you see that it goes up, and above 40, you see that it goes down. And you really have a cutoff. All the patients above 40 went down. All of them underneath went up, except some of them. And here you see those p-values. So we were happy. So next question was, okay, we have patients that came in 20 days after the surgery. And we had other patients coming up to 500 days after surgery. So does it really matter? And we split between less and more than 40. So here you see what happens. This is between 20 to 50 days, so it's pretty much, during the treatment. After that, you have up to 80 days after the treatment, goes up. And then more than 80 days after the treatment, it goes up. Above that, here, it goes down. Next step goes down. Next step goes down. So you see that whatever the length after you get the treatment, you still have a decrease. So it remains in time when you treat the patient. So that was really interesting. So the answer is it linked to the interval between V0 and V1? No. Are the data consistent? Yes. Below 40, tendency to have higher Rantis serum level. Above, lower Rantis serum level. And that was the most striking result. It's that here you have male patients. And here you have female patients. Which means that male were responder and females not responders. And that is something quite annoying, because when you work with medicines, you don't want to put on your leaflet, please, women, do not take this. This is not for you. Well, sometimes you have specific drugs like Viagra. It's the 25th anniversary of it. I had to cite it. But yeah, it's better to use it in that case. But this is not the purpose. So we looked at the split, 40. And what do we see? Less and above. Extremely significant. And on women, goes up. And there, above, it's just pretty much flat. And then we looked at, we had the chance to have all the data on the patients and their disease. They were all chronic patients. So we looked at chronic fatigue syndrome, trigeminal neuralgia, RA, and what we see is every time it goes down with males and it remains quite high for females, except in one case, which is breast cancer patients, which are female, by the way. What happened there is it goes down. So we said, okay, that's weird. Is there a difference between breast cancer patients and other women treated? And what we got was this. Female with breast cancer went down, and female without breast cancer went up. So that is something quite striking. And there is the link between what Dr. Lechner just said, is that when you have breast cancer, RANTES is there in very, very high amounts. And those patients were patients that were pretty much above 40 nanogram, all of them. So this is a bit of explanation of what it is. Just this is not on what we did, but RANTES was just first described in 1988. So this is not a brand new thing. It's fairly known. It was renamed CCL5 in 2000. And it's a chemokine from the CC group. It's secreted by several types of cells. At first, the researchers said it's only T cell specific. Only them can secrete them. And now, researchers realize that RANTES is pretty much secreted by every type of cells. You name them: platelets, macrophage, eosinophil, fibroblasts, endothelial, epithelial, even endometrial cells. And if you look at endometriosis, you have a very high level of RANTES in there. And what it does, here you have a nice blood vessel. It works through diapedesis. I just love that word. You feel so smart when you can place that word in a conversation. Diapetes is just the fact that when you have a chemokine there, you have a chemotactic gradient. And what happened is that those positive cells, which have receptors, just start nicely rolling next to the cells. And at one point, when they find a kind of crack between the two cells in the vessel's endothelium, they just go through. And for monocytes, for example, they will go through, go to the tissue, and then they will get activated by the other inflammatory cytokines. And you can find extremely nice films on YouTube of diapetes. It's really cool. So here you see the different type of cells that will be respondent to that chemokine. You will have monocytes, lymphocytes, neutrophils, eosinophil, dendritic cells, Th2 cells, Tregs, Th1, NK, and dendritic cells. Pretty much all of them. So this is back to breast cancer. This is pretty much how it works. It's quite linked to the amount of metastasis you can get. The higher the RANTES level, the higher the chance, the risk of having metastasis gets up. So this is just, talks and talks and talks. But the idea is just not linked to breast cancer. If you dig a little bit more into literature, you will see that ovarian cancer, prostate, pancreatic, gastric, melanoma, Hodgkin lymphoma, all of them have very high RANTES level. And this is just to show that Zhang and all did measurements of CCL5 in metastasis in luminal breast cancer. Here you see the serum level. This is what I told you before. Here you have a measurement by ELISA. And you see that you have up to 15. Here it's considered as very high. In our data, we went up to 160. And that's just due because this is measured by ELISA technique. It's a different technique, so the amount is not the same. Here you see normal patient. Here you have a stage 2 cancer, and here you have a stage 3. The more aggressive it gets, the higher the Rantes level. And here is the same, but that's the expression of CCL5. Here it's a normal patient, stage 2, stage 3. And here is a staining. Of course, it's not as nice as yours. This is just brown, you know, it's not nice, bright red. It's just brownish. But you can see that the more you go into, well, cancerous tissue, the more stains you get. And this is a very interesting study because that was done with estrogen-dependent breast cancer patients that were given tamoxifen. Tamoxifen is better known through Nolvadex. That's a typical anti-E2 medicine that you get for breast cancer patients. Here you see the microdialysis results of tissues from 10 patients in normal or breast cancer tissues. You see that here you have a significant higher level of CCL5 in breast cancer cells. Actually, they just took adjacent tissue where was not cancerous. Here, you have the same microdialysis of samples from 18 patients, but that we're treating during 6 weeks with 20 milligram per day of tamoxifen. And what you see is that here, when you have breast cancer and tamoxifen, it's reduced, which means that Rantes is estrogen dependent. And here, it's an in vitro experiment of the cells treated with estrogen and tamoxifen, and here you can see the results. It's quite, I'm looking at this one because it's kind of crooked. So you can see that if you have the control here, you have a significantly higher level with E2 reduced with tamoxifen. And so you can say that Rantes is estrogen dependent. So if you give tamoxifen, you will reduce the level of Rantes. The only teeny tiny problem with tamoxifen is the secondary effect of it. And that's why, in general, women want to discontinue taking that medicine because it has a lot of side effects. And they are all listed here. And it's not biased, you know, it's from drug.com, so I didn't make them up. So now, more and more, we're thinking about, okay, well, Rantes can be a target for cancer treatment. You have several ways of getting that stopped. You can either use CCR5 antagonist, for example, Maraviroc. Oh yes, I forgot to tell you. Rantes and HIV are extremely good buddies. No joke. High level of Rantes, low level of HIV. So that's why it's a target in HIV treatment. So if you take Maraviroc, Vicriviroc, which is not on the market, it was supposed to be on the market, but it was discontinued, and anibamine, which is extracted from amoeba, you have a blockage of CCL5 release. The only problem is you can take Maraviroc, but on there you have a black box warning for hepatotoxicity. So I'm not sure that your patient with high level of Rantes in NICO will really be willing to have serious life-threatening issues with hepatotoxicity when they get out of your practice. here you have Hodgkin lymphoma cells. Same thing. If you use Zydalic, you can stop RANTES secretion through another way. But the only problem is that you, again, have huge side effects. And here, same thing. You can try to target the EGF receptor pair. But then, same thing. If you use Iressa or Tarceva, which are anti-cancer medicine, you will get pretty much the same side effects, which are definitely not funny to have. So in conclusion, we missed the break. Sorry, I'm 10 minutes late. So in conclusion, when you have breast cancer patients, you have a trend to reduce the RANTES serum level by using RANTES 27CH, which is totally harmless. You have no side effects out of it. It's easy to take because it's pretty much sugar. And it's maybe used not only in FDOG patients, but also in a lot of autoimmune disease to reduce the RANTES serum level and hence the inflammation, because what RANTES does is just the starting point of inflammation, especially acute response. So what we are planning to do now is start a clinical trial with a pretty much large cohort of cancer patients. And we're planning on doing that in Belgium. So I really thank you very much for paying attention to me not being a dentist. And if you want to contact me, you can have my contact address here. And thank you very much. So if you have any questions whatsoever, feel free to ask. So is there any question? I thought I was completely clear. Cool.
There's also 2L inflame. So my protocol for reducing when I operate Nichols is giving 2L inflame.
You know, he's an extremely nice guy, but he's a German, kind of stubborn. So RANTES is the explanation.
I'm giving 2L inflame or 2L RANTES.
Which has RANTES in it.
Yes, I know.
So it's perfectly fine, and it will reduce the other cytokines.
But I'm giving it just shortly after the operation, and then I switch to 2L osteo.
That's an option, because it's this. I mean, it also have a lot of anti-inflammatory mediators in it. The difference is that if you give 2L inflam, it will reduce the inflammation first, which is extremely good, and it has RANTES, so we're safe. And if you switch to OsteoN after that, it's perfectly fine also, because when you start reducing the inflammation, you start the bone regrowth. Because when you look at the way osteoblasts are working and osteoclasts, rank L is pretty much extremely linked to a very high inflammatory process. So when you reduce those cytokines, you get rid of that rank L stimulation, and you have the stimulation with the bone morphogenetic proteins.
And the timing is right
perfect.
to keep 2L inflame about 1 week after the operation and then switch to...
No, you can go up to 1 month. 1 month of 2L inflam, and then you switch to OsteoN. So, because it will start giving anti-inflammatory will start the process anyways of bone reconstruction. So 1 month is fine.
Okay, so 1 month after the operation, 2L inflam.
No, you start it right away. You do the surgery and you tell the patient to start right away.
No, I start 3 weeks before.
Yeah.
So I keep it up 1 week after the
okay.
operation.
Well, yeah, that's fine then. I thought you would just give in 1 week. No. If it's like that, it's perfect, and then you give OsteoN. That's fine.
Okay, thank you.
You're welcome. Could I what? You know, I also have cards. So you don't have to take the picture. So are there any other questions? Gosh, I was amazingly clear. That's great. Cool. Well, then I guess you all want to have the coffee break. So that might be why I don't have any question. So.
Thank you. We continue at 11:45. So if you still have 30 minutes break, and we continue with Hans part 2. So 30-minute coffee break.
So was it okay?
Now I understand our research.
Yeah, you've not read the paper, so it makes sense.
I did it.
No, I'm joking.
Thank you.
So I leave the computer on because you talk
leave
right.
it on.
Yeah, you talk right after.
No, my next part is.
It's there. It's the neuralgia, right?
Is the ranges of metabolic products because no
Inflam and
it's
12
not sell in Italy.
I know.
Why?
Well, it's an old story.
Okay.
It was pretty much prehistoric time. No, it's just because we started with the products that are on the market in Italy, but we had lots of other products notified in Belgium that were put on the market after the Italian notification.
I understand.
And it was completely blocked. But
Is
you
it
can
possible?
get them, of course.
Okay.
You
Ordering directly
to the
Belgium,
pharmacies.
to the
Yeah,
pharmacy.
that's definitely